Good afternoon, everybody. My name is Alex Habib. I am the marketing coordinator for Baylor St. Luke's International Services, and I am filling in today. We are waiting on one of our physicians, our moderator, Dr. Al-Siraj, that got tied up. But thank you so much for everybody joining us. It is my pleasure to welcome everybody, all attendees and physicians from Latin America, the Middle East, and the United States, as a part of our mission to promote medical knowledge through educational programs. The International Center at Baylor St. Luke's in Houston, Texas, in collaboration with Baylor College of Medicine, is honored to host the 17th International Virtual Roundtable to our network of physicians, medical societies, and international medical community. Today's topic is the effect of metabolic surgery on non-alcoholic fatty liver disease. Allow me to explain today's program's format. First, we will have the lecture presentation by our speaker, Dr. Samir Gamil Mattar. Throughout this presentation, please feel free to submit all of your questions via the chat box located in the bottom right of your screen. Post this presentation, we will open virtual roundtable with comments and observations from our panelists. Then we will open it up to live questions from you, the audience. Before introducing our speaker today, I would like to welcome our international panelists who will join us after the presentation with their opinions and observations. Let's welcome Dr. Luciano Poggi Garland. Dr. Poggi is a general and bariatric surgery surgeon, graduated from the Universidad Peruana Cayetano Heredia. He's an associate professor of surgery and chief of general surgery at Clínica Angloamericana in Lima, Peru. He completed his research fellowship at Cleveland Clinic in Florida and his general surgery from the University of Oklahoma Health Sciences Center in Oklahoma City, USA. He obtained his bariatric surgery from Carmel Bariatric Center of Excellence in Carmel, Indiana, USA, and his advanced gastrointestinal surgery and endoscopy from St. Vincent's Hospital in Indianapolis. Dr. Poggi is American Board of Surgery certified. Welcome, Dr. Poggi. Next, let me introduce Dr. Mohammed Jamal. Dr. Jamal is an associate professor of surgery at Kuwait University, the chairman of the transplant department at Kuwait University, and a consultant metabolic and upper GI surgeon. He graduated with first-class honors from Aberdeen University. He underwent surgical residency at McGill University and obtained a fellowship in hepatobiliary and transplant surgery. Then he completed a second fellowship in advanced laparoscopy, robotics, and bariatric surgery at the Cleveland Clinic. Currently, he's performing hepatobiliary and bariatric surgery at Jabber Hospital. Dr. Jamal started the liver transplant surgery program in Kuwait in 2018. Welcome, Dr. Jamal. Thank you, doctors, for joining us. We will be connecting with you right after Dr. Mattar's lecture to obtain your observations and points of view. Now, it is my honor to introduce Dr. Samir Gamil Mattar. Dr. Mattar is professor and chief of division of metabolic and bariatric surgery at Baylor College of Medicine. He's also director of metabolic and bariatric surgery at Baylor St. Luke's Medical Center. Dr. Mattar is a bariatric surgeon and graduated from the University of Cairo in 1983 and completed his general surgery residency at Emory University in Atlanta, Georgia. He completed second general surgery residency at Vanderbilt University in 2000 and advanced laparoscopy fellowship at Emory University in 2002. From 2014 to 2017, Dr. Mattar has served as the chief of bariatric services at Oregon Health and Science University, as well as chief of the OHSU Surgical Weight Loss Center. From 2017 to 2020, Dr. Mattar was the medical director of the Swedish Weight Loss Services at Swedish Medical Center in Seattle, Washington. Dr. Mattar Dr. Mattar's main clinical areas of expertise include bariatric surgery and endoscopic treatment of acid reflux disease. He has developed comprehensive bariatric and metabolic programs with an emphasis on modern, high-quality, compassionate, patient-centered care. Welcome, Dr. Mattar.
Thank you very much for these very kind introductions, and thank you for inviting me to speak today. I am honored to be here and honored to be a faculty at Baylor College of Medicine, and really appreciate the fact that we have such authorities in metabolic and bariatric surgery joining me today, such as Dr. Luciano Poggi and also my friend Dr. Muhammad Jammad. I'm going to talk today about a topic that is becoming of increasing importance, not only in the United States, but across the world, and that is the rise of fatty liver disease. I'm going to share my screen now, and let's see. I believe this is it here. Okay. And so I'm going to talk about, because I'm a surgeon, of course, I'm going to talk about a very effective treatment for fatty liver disease, as you will see, and I will try to convince you, which is metabolic or bariatric surgery. So these are my disclosures. I'm a consultant for a small startup company, and this will have no bearing on any of the content of my talk today. As an introduction, I'd just like to remind the audience that non-alcoholic fatty liver disease is basically the deposition of abnormal lipids in hepatocytes and liver cells in the absence of alcohol intake. It's becoming very prevalent. In fact, it's gaining a rise in epidemic proportions in parallel with our obesity epidemic and in parallel with our diabetes epidemic as well. We calculate or estimate that about 25% of the world's population is estimated to have fatty liver disease. And this is not a benign condition, because in some patients, once the inflammation sets in, as I will show you, it can advance to fibrosis and then cirrhosis, and that can lead to liver failure or even hepatocellular carcinoma. So it should not be taken lightly. This is a recent, this is some data from a recent review article that was authored by our moderator, Dr. El-Sarrag. And he is actually projecting that Nash, which is non-alcoholic steatohepatitis, is projected to increase by 56% in the next decade. And he's also mentioning that the fatty liver disease is the fastest growing cause of hepatocellular carcinoma. And as we know, cirrhosis can be complicated by portal hypertension and liver failure. And Nash has now become the leading indication for liver transplantation in young adults. And essentially, this cartoon, which I got from the Cleveland Clinic, it shows the development or the evolution of this disease. We have what appears to be a liver that then has the position of fat, and it can stay this way dormant, so to speak, for many years. Or if subjected to inflammation by any of these causes, such as gut microbiota or oxidative stress, like in patients with sleep apnea, or any kind of inflammation, then inflammatory cells set in and they begin to transform the liver into a state of Nash or non-alcoholic steatohepatitis. And then fibrosis sets in, and then you get possible cirrhosis. And the incidences are important to remember. As bariatric surgeons, I can tell you that the majority of our patients, maybe 90%, maybe even 100% of our patients have an element of fatty liver in them. And then about 50, maybe 20, 25% of these patients are going to have this inflammation and development of Nash. And of those patients, a quarter of those patients may get cirrhosis. And as I mentioned, that can then advance to either hepatocellular carcinoma or hepatic failure with either death or liver transplantation. And you can see if this is rising in epidemic proportions, this is very alarming for our future, immediate future, and future generations. This is just a histological demonstration of what really happens at the tissue level. This is steatosis. As you can see, fat, when dissolved in the staining process of these cells, becomes these empty vacuoles. So all these empty vacuoles were deposited by fat that has dissolved. This is steatosis. And then once inflammatory cells set in, this is how we diagnose steatohepatitis. And then collagen starts depositing, causing this fibrosis. And gradually, as the fibrosis increases, and you can see all the fat here in the liver, then you get these bundles of collagen which shrink the liver and result in cirrhosis. And there are certain risk factors, of course, that are included in fatty liver disease. And these are some slides that I was able to obtain from our moderator. And there are major comorbidities that are well known to be associated with fatty liver disease, such as diabetes, dyslipidemia, of course, obesity and metabolic syndrome. And essentially, these are all important components of the metabolic syndrome. So I think it's safe to say that metabolic syndrome is a major perpetuator of fatty liver disease and NASH. And then there are emergent associations. We're seeing more and more patients who have hypothyroidism, sleep apnea, polycystic ovarian syndrome, and so on, who are also being subjected or developing higher levels of fatty liver disease. With regards to obesity, we've known for a while now that it is very closely associated with the BMI, such as BMIs increase in amount, so does the incidence of fatty liver in these patients. So that by the time their BMI is above 35% of these patients have fatty liver. And I can tell you, and I'm sure my fellow panelists will agree, that the majority of our patients that we see their BMI is 40 and above. And so you can imagine how our patients, the majority of whom have liver disease, have NASH, or more other diseases. So this again explains how obstructive sleep apnea can provoke or increase NASH in patients. The chronic intermittent hypoxia, the events that happen during the night when the patient is sleeping, sometimes as much as 100 events per hour. These can cause inflammation and gene expression that results in lipogenesis and fibrosis. And this is really what helps advance this disease process to steatosis and NASH. Also, diabetes has been found to be closely associated with NASH. This is a study from John Dixon in Melbourne, Australia, where he reported a smaller incidence of NASH in patients without diabetes or hypertension. But when they developed hypertension, it rose. And then when they developed diabetes, it rose even more. And then it really increased in patients who have both diabetes and hypertension, meaning that both disease processes are subject to converting fatty liver disease into NASH. So fatty liver disease seems to be, I think everybody can agree that it is the hepatic component now of metabolic syndrome. And as you can see from this and what I've mentioned, it's very closely associated with hypertension, with diabetes, and cardiovascular disease, all of which are important components of metabolic syndrome. So it's no surprise that the majority of our patients have fatty liver disease and, of course, are exposed to the problems of NASH. And that is the problem, in that we want to save the patients from developing NASH before it becomes a serious disease. And these are some risk factors or red flags, if you will, that should alert any clinician that the patient might be developing NASH. And I say this because NASH is not a disease that is visible by the naked eye or palpable by the human hand. So there are as I mentioned, I will mention about the liver biopsy is the gold standard for diagnosing NASH. And we have to decide who should get a biopsy or not. And these are the red flags: the age of the patient, gender, males more than females, Hispanic race, hypertension, obesity, diabetes, as I mentioned, elevated liver levels, liver function, insulin level, and very importantly, the PNPLA3 genotype. And these should alert the clinician that maybe they should proceed with a liver biopsy. And this is because NASH, as I mentioned, has an important effect on reducing the survival of patients. It increases liver-related mortalities, it increases cardiovascular mortality, and cirrhosis alone is an independent risk of death. So I just got this from a recent publication on the algorithm that some clinicians may want to follow. And essentially, they state that if you have patients who are, say, for example, obese and have fatty liver, or you suspect have fatty liver with diabetes, then you should check their ALT levels and then risk stratify them by either using the fibrosis index 4 score or the non-alcoholic fatty liver fibrosis score. And if this is a low number, then you can be reassured that the patient most probably does not have fatty liver. However, if the risk is high, if the numbers are high, then there's a high risk. And the best thing to do is to refer these patients to a hepatologist who will then proceed with further testing, especially vibration-controlled transient elastography, which is fibroplasty. And based on that, they can then determine that the patient has a high likelihood of having fibrosis or NASH, and then proceed with liver biopsy if needed. So now that we have an idea about the epidemiology of this disease and the factors that lead to it and how serious it is, let's talk about its treatment. And I can tell you right now, the best treatment for NASH and fatty liver disease is, and the whole spectrum really, is weight loss. Weight loss alone can help improve can help stop the advancement of this disease and maybe even reverse it. And as this important study shows, that a weight loss of as little as 5% of total body weight can increase insulin sensitivity, can reduce ALT, can reduce the fat in liver. And a weight loss of 9% or more can actually make a considerable improvement in histology. And this is another study where they this is a randomized control trial of intensive lifestyle change and weight loss. And you can see from this graph how there was an improvement in the NFALD scoring system with weight loss. So there's no question that having patients lose weight is the key to successful treatment in these patients. So unfortunately, there is no, at this time, there is no medication, there is no drug that has been approved for NASH. There are still some in stage 3 or phase 3 trials, but they haven't been marketed yet or approved. So as I mentioned, the weight loss studies can cause some improvement in patients in prospective studies. There has been no medical intervention that has been shown to reduce or reverse fibrosis. And there are unknown benefits of the treatment of the liver, other metabolic morbidity, or survival. And so we come to surgery. As you know, and I think my audience will readily agree, that bariatric and metabolic surgery has been shown to be the most effective method of sustaining prolonged, durable, and safe weight loss. And so in this study that I did when I was with Phil Schauer in Pittsburgh, we decided to look at our patients who had fatty liver disease and the effect of surgery on them. And the study design was a very simple one. We would operate on these patients and at the time of surgery, do a liver biopsy and then rebiopsy them later, a year later, to see what histological changes they had in addition to whatever laboratory parameters we were measuring. And the patients got a mix of 3 main operations. They had the Roux-en-Y gastric bypass, some had a sleeve gastrectomy, and this was in the early days of the sleeve, and some had the adjustable gastric band because at the time we were doing these with quite raised frequency. And this is how we did our liver biopsies. We used the TrueCut needle that we advanced through the anterior abdominal wall directly into the substance of the liver and got a decent, nice core of liver tissue that we submitted for histology. This is the mix of cases that we had. You can see the majority of them were gastric bypass and then sleeves and just a few gastric bands. And here are some of the histological results. This is the biopsy at the index operation, and you can see there's a lot of fat here, a lot of fibrosis. And this is the same patient only 8 months later. And you can see that their architecture of the liver has become essentially normal. This is normal liver architecture in only 8 months. Here is another patient, same story. This is at 13 months. And these were patients who had to come back for a variety of reasons. For example, a gallbladder operation or a diagnostic laparoscopy, or were biopsied at the clinicians, at the hepatologist's clinic. And so this is the nice thing about the study is that each patient was their own control. And this is a summary of our results at the time. At a mean of 1 year, there was a 37% resolution of steatosis and inflammation and a 20% resolution in fibrosis. We were able to resolve or clear fibrosis. And the histological changes were not associated with any increase in inflammation or fibrosis, because this was an occasional concern that some patients may actually do worse with bariatric surgery. And it also, the patients had marked improvements in the other components of the metabolic syndrome, such as their cholesterol levels, hypertension, diabetes, and so on. So that study was about 15 years ago. So I looked for a more recent study, and this is a meta-analysis here of 21 studies, again, a mix of different procedures. And this was just recently published. And it shows in terms of steatosis or fatty liver, 88% of patients had improvement in that, as you can see from this chart. And then in terms of Nash, 59, almost 60% of patients had improvement. And then in terms of fibrosis, 30% of patients had improvement. So across the board, metabolic surgery was able to improve all the features of fatty liver disease and its consequences. Now, let's talk about liver transplantation, because as I mentioned, a lot of our patients end up declaring themselves with liver failure as a result of fatty liver disease that might have gone undiagnosed. And we, as bariatric surgeons, receive a lot of these patients because weight loss is mandatory in these patients who are waiting for liver transplant. It's very, very rare that a patient whose BMI is above 40 or 45 will receive a graft. And so we have been operating on these patients by giving them, say, a sleeve gastrectomy to allow them to optimize them and allow them to become eligible for liver transplantation. One of the problems, though, that these patients used to have, or still have, of course, is portal hypertension, which was pretty much determined to be an absolute contraindication to bariatric surgery because the risk of exsanguination on the table was so high. And these were patients who really had no resorts. They had no means of therapy, no options, because surgery wasn't available and the liver transplant they were not eligible for. So these patients are obviously screened for varices, and we take care. The important thing is to make sure we can map with CT scans and others what their varices and collaterals look like. And then one way to get around the portal hypertension issue, if they do have it, is to place a TIPS shunt, which tends to reduce portal hypertension quite effectively as long as you take good care of these patients. And this was our experience in Indiana. We had about 5 or 6 patients that we studied. Their mean initial gradient pre-TIPS was 22, and we were able to reduce it to 6 and then successfully operate on these patients and then deliver them to the liver transplant team. We prefer to do sleeve gastrectomy in patients with liver disease, especially advanced liver disease, for the following reasons. First of all, the sleeve is a less complex operation. It's a shorter operating time. We're able to get them off the table quicker. Most importantly, it maintains endoscopic access to the biliary system. It's associated with less nutritional deficiencies. and less malabsorptive potential problems. Of course, they are immune pretty much to bleeding mucosal ulcers because there is no anastomosis. And the weight loss and comorbidity efficacy is pretty much equivalent to gastric bypass. So I know I've covered a lot of ground. I'm just going to conclude by summarizing some of the important findings and messages that I'd like people to hear. And that is that fatty liver disease is rising in epidemic proportions, parallel to the rise in obesity and metabolic syndrome. There's a risk of progression to Nash, cirrhosis, liver failure, and cancer, and so it is not a benign disease. Weight loss, by any means, of course, the more the better, is the cornerstone of fatty liver disease. Metabolic surgery, as we know, is the most effective weight loss modality at this present time. And the sleeve gastrectomy is the preferred option, so long as we obviously preoperatively optimize the patients as much as possible so that we can deliver safer outcomes. Thank you very much. I obviously live here in Houston. It's a great city, and I welcome any of you to come. I'd be happy to host you and show you around and have you visit our institution.
Thank you, Dr. Mattar, for a fantastic presentation. Hi, joined late. My name is Hashim Al-Sarrag. I work here with Dr. Mattar at Baylor College of Medicine. I'm a gastroenterologist and hepatologist here. And I think this is a small enough group that you can just, if you have any questions or comments to Dr. Mattar.
Great talk, Dr. Mattar. My question is now, I mean, you were one of the first people in your fellowship to study the effect of bariatric surgery on Nash. And that was a great study as well from Indiana. What are you doing now for the liver cirrhosis patients who are listed for transplant?
So
the bariatric, the obese ones who are already on the list for transplant.
I assume you're referring to patients who are severely obese or morbidly obese.
Yeah.
Who want to receive. So these are the patients that we receive, and we start off by conducting a series of investigations. The most important thing we want to see is if they have what the level of liver failure is, and if they have portal hypertension or not. Because if they do have portal hypertension, I can tell you it's extremely dangerous to operate on these patients. I would not risk it. And so we used to turn these patients away and tell them, sorry, your risk is too high. But ever since we started applying tips now, and we work closely with the hepatologist to do this, because TIPS is not also a benign procedure. Putting a shunt in the liver can cause hepatic encephalitis or other problems. So if we all agree, then we apply the shunt, reduce their portal hypertension, wait about 3 to 6 months for that to happen, and then re-image them and re-evaluate their portal pressures. And if they have come down, then we offer the patients a sleeve gastrectomy for the reasons that I mentioned. And that is, most importantly, you want access to their biliary system.
Thank you. I think for the interest of time, since again, small enough group, people can send their questions, but perhaps we can have the next presentation from Dr. Poggi. And then followed by.
Good afternoon.
Good afternoon.
Thank you for the invitation. I need to be allowed to share my screen, please.
Of course.
What? You heard wrong. There are no slides here. You just have to talk.
So I'm a surgeon as well, but recently, at least my practice here in Peru, the obese patients that we see are way smaller than you can see in the US and probably in the Middle East. And another interesting thing to know is that most of our patients here in Peru, pretty much all of them, have to pay themselves for the surgery. So actually insurance don't cover these procedures. So that allows us sometimes to, I guess, probably operate on people that have a BMI of 30 and start seeing maybe early therapy in patients that have fatty liver. But also, and recently, at least in my practice, we are having a really high demand of no surgeries. So I'm talking about endoscopic procedures. And I think I'm changing a little bit the topic, but I think this is an interesting perspective, and at least what I'm seeing in my practice every day. I have nothing to disclose. So Dr. Mattar already mentioned this. In Peru, we exactly don't know what is the prevalence of fatty liver. And of course, fatty liver is a larger spectrum of disease. In probably the difference between the reported prevalence in different studies varies according on how did you get the diagnosis. So not a lot of people get the diagnosis doing a biopsy. So there are some studies reporting fatty liver just with ultrasounds or some fiber scans. So in Peru, the overweight prevalence is around 40%, and obesity ranges between 15 to 20%. So I don't think, again, these numbers represent how obesity is in Peru, because again, most of our patients are probably between, I would say, 30 and 45 of BMI. And we rarely see patients above that. And I still remember practicing or training in Indiana, and the average BMI that we would do surgery would be 50. And actually, I remember my boss saying, there's a BMI of 50, that's a fellow case. And that's not what we do here in Peru. So, but something that is not different here in Peru is that the number one cause of cirrhosis is actually Nash. And as Dr. Mattar said, is nowadays, and probably this changed in the last 5 years, Nash is the number one cause of liver transplantation. So again, due to cirrhosis. And alcohol is only 11% in Peru. And actually, I thought that we Peruvians, we used to drink a lot of alcohol, but actually we don't compared with the rest of the world. So what do I want to say about Nash? For sure, the overweight patients have Nash as well. And usually we don't see these patients in the bariatric clinic, but we see a lot of time these patients just referred by some other physicians in terms of what can we offer them to treat their Nash or their fatty liver. And I think this is where we should start to look for in terms of prevention. How can we prevent fatty liver to go to Nash in patients that are not candidate to surgery, or in patients that actually decline that option? So, and we know that life modifications and diet prescriptions are very limited. Probably 10% of patients will achieve the 10% weight loss and will keep it and have a benefit. But again, we have options, and this is what I'm seeing in my practice. I'm seeing a high demand of patients that are overweight, that are not surgical candidates, at least in my practice, that are looking for options. And this is one option that I think is starting to grow again. I think balloons, intragastric balloons comes and goes. But what we're seeing is that balloons work and can help patients with fatty liver and even Nash. And actually, when we work in a multidisciplinary fashion, we can have our endocrinology friends to add some medication and actually see the improvement in terms of not only the inflammation, but also as well in fibrosis. And this is only with balloons. I still think, and the literature proves that bariatric surgery is the number one therapeutic option for obese patients. But again, we're seeing a lot of patients, at least in Peru, with mild and moderate obesity that are not candidates for surgery or don't want surgery, and overweight patients with Nash as well. So what do we know about gastric balloons? We know that there are some dependent, weight loss factors that will help Nash, but we also know that there are some metabolic pathways. So even this small therapy that sometimes doesn't work that well causes changes in gastric emptying, delaying it, and also decreases ghrelin, that is the appetite hormone. And this translates in improvement in Nash. So again, and this is still, I think, fresh out of the oven. In last 2 months, the FDA approved the use of intragastric balloon for Nash. And I think this at least opened my eyes in in using more frequently intragastric balloons as an option for patients with, again, this disease. So in this all based in a Mayo Clinic cohort where they studied only 20 patients with liver biopsy done during the placement of the balloon. And they did an EUS biopsy, and they actually found that the NAS score was improved in 18 patients, and actually that it decreased at least 2 points in 16 of 20 patients. 15% had histologic regression of fibrosis, and magnetic resonance elastography showed that there was at least a 50% improvement. So these, I think, are big numbers. And again, I think I wanted to bring this topic to discussion because what we know is that you need to have 10% of weight loss to achieve results in terms of NASH. And you can get that through something besides surgery. And the question, again, that I want to see if we can answer is, why, if patients lose more weight, we might not see even a better result? And I think that's a question that we can't answer. I mean, do patients that lose 20 or 25% of their weight will have better results in terms of NASH resolution or improvement? And that's, I think, a pretty important question that we should try to address. I don't have the answer, of course, of that. So I think in terms of future directions, intragastric balloons can fill an unmet need to improve health of NASH patients, especially the overweight patients, and can be used actually as a step-up approach, considering that all these patients with mild, moderate obesity associated NASH that will not be candidates for surgery. I think we should look for cost-effectiveness studies to really see what way do we need to go in terms of offering procedures or therapeutic options for our patients. I'm going to stop sharing. I don't know if there are any questions regarding this. I'm changing again the topic a little bit of discussion, but I think that nowadays we're focusing a lot in prevention of disease.
Thank you very much, Dr. Poggi. I remind the audience that they can submit their questions through the chat box on the right lower corner. And I think it's time for us now to hear from Dr. Jamal from Kuwait University. Dr. Jamal, your turn. Unmute yourself, please.
Thank you, Dr. Siraj. I'm honored to be with the distinguished group of speakers. So basically, I was asked to focus mainly in 5 minutes on about NAFLD in the Middle East. We recently, and following a consensus meeting, we decided to change the term NAFLD to MAFLD, which is metabolic associated fatty liver disease. And as Dr. Mattar elaborated, it's really a symptom of severe metabolic disturbances. The prevalence varies. It can be estimated between the prevalence of NASH can be estimated to be between 6 to 35% in the population, and it's variable. We know that with more obesity, we will get more MAFLD, and NASH, 85% of the morbidly obese, BMI above 35 will have evidence of fatty liver disease on ultrasound, at least. It is the #1 growing cause of for indication of transplantation worldwide. And among different global burden of disease subregions in 2017, women living in the Middle East and North Africa ranked first, and men living in the Middle East and North Africa ranked second for disability-adjusted life years, DALYs, due to metabolic risk factors. The prevalence of what was previously termed NAFLD has risen in parallel with lifestyle changes and has had direct clinical and economic impacts. According to the Global Burden of Disease study, mortality related to chronic liver disease ranked 11th in all causes of DALYs, resulting in 524 years of life lost per 100,000 of population. Men in Kuwait and Qatar especially had the highest prevalence of cirrhosis, more than twice the global estimate. In 2018, we started with, this is our first liver transplantation case. The issue in Kuwait is that the population is only 3 million, and for a small country to start the liver transplant program, especially, we decided to do a cadaveric program first before embarking on a living-related program. So you understand, it's very challenging to start a cadaveric program in a small donor pool in Kuwait, but we managed to do that in 2018. So far, we did 14 cases. This is our paper on transplantation describing our model of how to start a liver transplant program in a small country. And we included only our first 11 patients. Out of them, 9 were transplanted for Nash, 1 for alcohol cirrhosis and 1 for hepatitis C. In fact, even in the patient who had alcohol cirrhosis and the patient who had hepatitis C, they both had also element of Nash, so they had a combined disease. I can tell you now in our list, we have about 30 to 40 patients, 95% are those due to Nash. I was recently a member in the Economist Intelligence Unit report. We had a consensus meeting and we published this report to raise awareness all over the world about the epidemic of NAFLD, and you can find this in the Economist Intelligence Unit website. The report title is "Sounding the Alarm on a Global Public Health Challenge." And what we highlighted is really that we need to have action on this disease. It's a silent disease. The governments and local authorities are not taking great care of it. We just tell the patient you have fat in your liver and you need to exercise and lose weight, and that's it. There is a famous case in Australia in 2012 for a Colombian refugee who sued his primary care doctor for having a hepatocellular carcinoma. He sued his primary care doctor because he told him, you have obesity, you have fat in your liver, you need to lose weight. And he sued him because he did not refer him to a bariatric surgeon. And he actually won the lawsuit initially, but then lost it in the second order of the court. The comorbidities associated with metabolic fatty liver diseases, of course, we all know that: high blood pressure, diabetes, obesity. The issue is, and I was very interested by the study that Dr. Mattar alluded to, the OSA study. We are seeing in Kuwait, we are operating in a lot of NASH patients doing bariatric surgery. And we used to think that it's actually due to uncontrollable diabetes, and those with a high HbA1c will have a high prevalence of cirrhosis. But actually, we are seeing it in the younger population and with a well-controlled disease. Like we are seeing cirrhosis in patients with HbA1c of 6.5. Maybe OSA is playing a part in that. Of course, further studies are needed. We certainly need to have a referral system. I mean, even in this consensus meeting with the Economist Intelligence Unit, I was the only bariatric surgeon there, and there seems to be a lack of understanding of the effect of bariatric surgery on this disease. It's a massive effect. These are some of the studies alluding to the Roux-en-Y gastric bypass effect on NAFLD. We recently published a chapter in a Springer book on sleeve gastrectomy, detailing all the studies on the effect of sleeve gastrectomy on liver cirrhosis, not only on NAFLD. And this is a summary of some of the studies. There is a meta-analysis that is more updated that Dr. Mattar referred to. I'm I'm concluding my talk by saying that really awareness is key. There is a lack of awareness among the medical community and the policymakers, and this is the new diabetes. Like we are having an epidemic of it. Kuwait is an obvious example. MAFLD is the new diabetes, and metabolic surgery is the most effective option. We use endoscopic treatment heavily in form of gastric balloons, the 1 year or Beira balloon, the 6 months balloon, and the ellipse balloon. And we are seeing some effects, but unfortunately in the cirrhotic patients and in those with varices, we cannot use those endoscopic treatment. We have a lack of expertise relatively with tips in Kuwait, so that makes our job harder in treating those with portal hypertension. But we really need to push the boundaries in terms of bariatric surgery in cirrhotic patients, because the pool of transplant donors will not cover all the patients who are going to need liver transplantation. And we need to expand the boundaries. We need to push hard as bariatric surgeons, maybe doing, because a liver transplant in patients in a patient with Nash is a palliative procedure. They are going to have Nash again in their transplanted liver. We need to think of performing bariatric surgeries at the time of transplantation or post-transplantation. Further studies are needed in that, and I think that's also a topic that needs good research and discussion. Thank you.
Thank you, Dr. Jamal. Wonderful. So we have now 10 minutes for some discussion. I haven't received questions, so I'm going to start first with the obvious, and I will take from where Dr. Jamal left over. There's this new named entity called metabolic dysfunction, fatty liver associated with metabolic dysfunction, MAFLD. 1 billion people around the globe are estimated to have it. You don't need to remember many things. It's fatty liver plus either obesity or diabetes puts you in that entity. I do feel sympathetic towards primary care generalists, non-surgeons, non-hepatologists, for them to be confused in the masses of people with MAFLD. Who do they refer to you, the bariatric surgeons? So I know you all said so many things, and by nature, you tend to go into the more sophisticated and rare. So I would like you to step back and tell your garden variety primary care who sees 20 patients a day, who to think of to consider for bariatric surgery. Just basic stuff. And we can start perhaps with Dr. Mattar.
Thank you, Dr. Hashem. And that's that's an excellent question, because I get it all the time. And you're right, we tend to think of extremes because as surgeons, we're always looking for challenges. But the reality of the fact is most patients are, the normal, simpler patients. And so the one message I have to referring physicians is send patients early. What happens is many physicians will wait and sit on the patient trying different options. Let's try lifestyle, let's try dieting, let's try medications, let's try exercise. And then as a last resort, they will send patients to us. And by that time, their fatty liver disease has advanced in the continuum of the spectrum to higher degrees of cirrhosis. So what I recommend is, if you have a patient with clinically severe obesity, meaning a BMI over 35, send them to our weight loss centers, where most of us now have multidisciplinary approaches. We have the ability to apply multidisciplinary options for these patients, which may or may not include surgery. But at least they'll get into the system, and we will be able to treat them before the more advanced stages of disease set in. I don't know, what do you think, Luciano or Muhammad?
Yeah.
Well, I agree 100% with what Dr. Mattar has just said. It's been, I think, a challenge to have a good, agreement with our clinician colleagues, because a lot of patients, again, I refer pretty late. So Here in Peru, things are a little bit different. As I mentioned, insurance don't cover any type of bariatric procedure, and patients are, most of them, encouraged to look for a weight loss center or a bariatric program starting with a BMI of 30. So usually, again, there need to be some criteria, like obviously several years trying to lose weight, having some medical problems associated, and of course being willing to change some lifestyles. But we like to talk with our, I guess, primary doctors and as well as endocrinologists, cardiologists, that patients need to be referred as early as possible if they already tried an alternative therapy for surgery. And it's very common to see patients that have been on metformin, for example, or a drug, and then they stop the drug for a couple of years, and then again the same drug, or they change for another one, and they try again diet modifications and exercise programs without having any success. So I think it's going to get better with time, but access to surgery is still not as good as we would like it to be.
I think that's a very good indication for referral, and also everybody would agree in that. But I think any diabetic with a BMI above 30 and fatty liver also should be referred. Any diabetic at any BMI with deranged LFTs should be referred, especially with the high waist circumference. I think the waist circumference is the key in those with fatty liver disease and metabolic syndrome with diabetes. And if you start noticing, you will see that those with Nash are the ones who have a central obesity. They will be the ones who are at highest risk of developing Nash and fibrosis. And now with the FibroScan readily available, I mean, the primary healthcare physician can refer them probably to the hepatologist, and with the FibroScan, the hepatologist can also refine the referral. But I think any diabetic with a BMI above 30 should be referred. I don't think there will be a great resistance to that referral.
Thank you very much. I want to add to the primary care, and I again always plug with Dr. Jamal here. There are now pathways that you could look up, and I'm happy to send them after that, where you have things that are calculators like FIB4, NAFL fibrosis score, and it allows you in a busy practice to identify high risk from low risk. And after that, there are tests like FibroScan, where you can actually obtain some quantification of the fibrosis. So the people referred to surgery would be the ones with some degree of fibrosis indicative of Nash. And that helps you filter a lot of people relatively fast if you get your algorithm correct to identify that high risk group. Now I'm going to move to the other extreme to oblige you. There is an entity, particularly in the Middle East and the Indian subcontinent, of non-obese Nash NAFL, that they are not completely non-obese, but they're not the morbidly obese that most of us are attuned to. So perhaps I could start here in a reverse order. Dr. Jamal, do you see that entity, or is the experience in Kuwait more traditional, obese cirrhotics?
Yes, we do see that often. Again, in those population, you will find that, I mean, I'm sorry to talk without quoting research and data. I'm really interested in.
You're the expert here. We don't need that.
Yeah, but we see that in patients with a strong family history of diabetes. And if you see the natural history, probably fatty liver is one of the first signs in patients before the development of diabetes. Like you will see them having fatty liver, and in 5 years they will get diabetes, and in 10 years they will go to a BMI of 32 or 35. We share a similar issue with Peru, in which that we have a government practice and a private practice, and in the private practice, most of the patients are self-referred. We use Saxenda liraglutide heavily in those patients. We did not perform any liver. Patients here are very resistant to liver biopsy, but we should have performance studies utilizing the FibroScan, but we haven't done that yet. But I think liraglutide and the new drug semaglutide might have a great result in those patients. It's an expensive drug, but people here are, are from the higher socioeconomic classes, and we heavily use liraglutide in those patients.
Thank you. I'm going to shift it to maybe last couple of questions to Dr. Mattar and Dr. Poggi. Again, a simple-minded person. I'm referring a person to you. This person is obese. They have Nash. They have advanced fibrosis. They're not cirrhotic. I want to tell them I'm referring you to Dr. Mattar. He's going to do a surgery. What happens after that surgery? What is a realistic prognosis for someone who has Nash and obesity for whom you operate successfully? Are they going to be cured 100%, 50%, 3%, over how many years? I'm interested in all of the three of yours perspective on how to counsel patients about what is realistic, data-driven prognosis after bariatric surgery for someone who has Nash.
Wonderful. Thank you so much, Dr. El-Serag. Of course, we base all our conversations with patients based on expectations. And it's important to define the word cure. Every patient's definition of cure is different. So I explain to my patients that based on our experience and based on published data, we expect you to lose a certain amount of weight. I can tell them, just to make it real to them, I can say 15, 20 pounds, or I think that's equivalent to 7 to 10 kilograms every month for the first 2 or 3 months, and then it slows down until it stabilizes at about 16 to 18 months. But I can also say that based on our information and the studies that we did, your liver is going to improve. The fat in it is going to dissolve, the inflammation is going to reverse, the fibrosis might also reverse to a certain extent, and I give them the percentages, 80%, 50%, and then 30%, depending on the stage. And I tell them that at least what I don't want to say guarantee, but what we'll most likely do as a result of this surgery is stop the progress, the relentless progress of this disease into cirrhosis. And in fact, we might actually reverse the disease. And also, by the way, we're going to improve your diabetes, your hypertension, your sleep apnea, your hypercholesterolemia, your gout, and your joints.
Wonderful. Dr. Poggi and then Dr. Jamal.
Yeah. Well, thank you. I don't think I can say anything better than what Dr. Mattar just said, but usually what I tell patients is that depending on the degree of Nash and fibrosis is that we can set the expectation. So usually if, and this happens a lot, we have a patient, the patient has Nash or at least suspicious of Nash. We don't have a biopsy yet. We get to do the surgery and then we get to do the biopsy. And sometimes we find things that we don't like to find, like a cirrhosis. And actually that's when we need to have a more realistic discussion. So a lot of times if there are no stigmas of cirrhosis or advanced liver disease, I think we can tell the patients that there is at least a chance of 50, 70% of having their liver improve, or actually Nash pretty much put on remission. Again, as Dr. Mattar said, the word cure is a word that we are trying to avoid nowadays for all these chronic diseases. So, so I usually like to have the conversation after I've done the biopsy, that sometimes I don't do it routinely after the bariatric surgery.
Dr. Jamal, have the last word, please.
So I agree with Dr. Mattar, but again, which Dr. Poggi referred to, the paradoxical fatty liver, when you have severe weight loss in some patients. So you really need to follow them very closely, make sure that they are having proteins, check their HbA1c. You don't want to have a very low HbA1c. That might indicate a paradoxical fatty liver. We remember the GI bypass. I mean, with the GI bypass, 10% of patients developed liver failure. I recently had a case of a sleep patient who went into acute liver failure 6 months post-sleep. And when we examined her, we found that she was severely malnourished because she had a sleeve twist. And instead of transplanting her, we did a balloon dilatation, put NNG, did some good feeding, and she reversed her acute liver failure just with the nutrition. So we need to be careful with these patients, especially those who are cirrhotic. They need to have very good nutrition in the first year so that they don't go into a worsening of the liver disease.
Thank you. Well, I would like to take it to a close. I would like to thank our doctors for their expert reviews tonight.
I have a question for you,
Tfaddal.
because somebody was asking me about it yesterday. What do you do with liver donors who had gastric bypass?
What do we do with liver donors who had gastric bypass? They still qualify.
Yeah,
They qualify fine, yeah?
I'm
No,
surprised. Why wouldn't they qualify? They're
yeah, I know, but
healthier
I'm
than.
just saying, I just want to know what is the, if you do anything special for them. I just said that you just can't take it. It will be a great liver.
Yes.
Yeah,
Yeah.
the best liver.
Yeah. So that's a good finale. Before we finish, Baylor St. Luke's would like to recognize and acknowledge the following entities that you will see on your screen now. So we'll have a video now. And we would like to remind all of you that today's session is recorded and will remain available in our channel. We invite you to subscribe to our CHI St. Luke's Health YouTube channel for information on our next international virtual roundtable. Thank you, everybody, and good afternoon in Latin America, and good night and تصبح على خير in the Middle East.
Thank you. I learned a lot from you guys. Thank you.
Thank you.
Oh, no. Thank you.
Thank
We
you.
learned a lot.
Thank you, Dr. El Sarag.
Bye-bye.
Bye-bye.
Everybody. Bye.